Hello, this is Dr. Mark Rosen, and today we're going to be talking about cardiac effusions and tamponade, specifically how it relates to ultrasonography in the intensive care unit and the emergency department. We'll start off with two questions. Question number one, which of the following is correct? A, about 60% of patients with tamponade present with Beck's triad consisting of jugular venous distension, hypotension, and muffled heart tones. B, about half of patients with large pericardial effusions eventually will develop tamponade. C, electrical alternans may be seen due to the heart swinging in a large pericardial effusion. Or D, there needs to be about 200 cc's of pericardial effusion to cause a chronic tamponade. If you're listening to this online, you may want to hit pause to think about these answers and take your time. And now we're going to go over the correct answer. The correct answer is C. Electrical alternans may be seen due to the heart swinging in a large pericardial effusion. The electrical alternans can not only be seen on an EKG, but oftentimes on the telemetry monitor at the bedside. A is incorrect. In reality, about 25 to 30% of patients with tamponade, the minority, present with Beck's triad. The same goes for a large pericardial effusion developing tamponade. That's about 25 to 30%. It's a substantially large number, but it's not half. And D, 200 cc's of pericardial effusion would definitely cause an acute tamponade, but not chronic, where the pericardial sac can be stretched and can hold up to 2 liters of fluid. Question 2 is really made to test your skills on interpreting the various views of cardiac imaging. So on this one, the parasternal long view, which is not typically seen? The right atrium, the left atrium, the right ventricle, or the left ventricle. So which of the following is not typically seen on the parasternal long view of the heart? If you're unsure about this answer, you may want to go back to some of the prior lectures on imaging the heart. However, we will go over some of this during this lecture on pericardial effusions and tamponade. And now for the correct answer, the right atrium. And we'll discuss this more in detail as we go on. So now let's stop on the side of the road here and have a little bit of philosophy on why I consider ultrasonography an extremely useful tool in imaging the heart. So here's the 405 for those of us in Southern California. I'm sure you recognize it.
Welcome to the 405 freeway, Southern California. And I think we could agree two things about this freeway. It's one of the busiest places, so there's a zillion cars, but nobody is driving blind.
So if you don't drive blind on the freeway, why would you ever examine patients blindfolded? And to me, that's kind of what it's like using a stethoscope. Now, don't get me wrong. A stethoscope is an important part of the physical exam, and a cardiac ultrasound should never take the place of a good physical exam. Physical exams are crucial, and that should never be misunderstood. But ultrasonography can oftentimes greatly enhance the physical exam. So, for example, in this image, we can see at the arrow, the left atrium, the mitral valve opening and closing. Over here are the walls of the left ventricle, this being the septum. The blood flows from the atrium into the ventricle, gets pumped out the aorta, where we pass by the valves over here, the aortic valve. Just anterior is the right ventricle, and surrounding the entire heart in the pericardial sac is a fairly large pericardial effusion. And in fact, you can see the swinging of the heart that creates electrical alternans. Pericardial effusion is actually normal if it's a normal size. So the typical pericardial effusion in a normal heart is somewhere between 1 and 2 tablespoons, 15 and 30 cc's. The etiology is somewhat varied, where most literature will cite infectious malignancy, collagen vascular, chest radiation, and so forth. But it's important to realize that depending upon your institution, renal failure may be an important etiology of large pericardial effusions. If a person comes in with missing several dialysis treatments, for example, the pericardial effusion can be rather large or even cause tamponade. Acutely, the pericardium holds up to 200 cc's. More than that, tamponade will ensue. But the pericardium stretches over time, so it can hold up to 2 liters if the fluid accumulates slowly, as it frequently does in chronic diseases. However, cardiomegaly, as seen on an X-ray, is a very late sign and typically occurs after 250 cc's of fluid have accumulated. It's often important to talk about the size of the effusion. It's good in terms of communicating the size to other clinicians, and it's very important in terms of following the effusion. A small or medium-sized effusion in a critically ill patient can develop into a large effusion that can cause tamponade. And again, tamponade from a large effusion occurs in 1/4 to approximately 1/3 of the patients. So first we can estimate the size of the volume. Small volumes are typically less than 100 cc's, large greater than 500, and medium size in between. And there are 2 parameters that I look at on the ultrasound. One is whether the fluid is loculated or localized. If it's localized, think of a small or medium-sized effusion. If it's circumferential, think of a large effusion. The bandwidth of the effusion, the area that's typically anechoic, is also somewhat crucial in terms of measuring the size. Greater than 2 centimeters is typically associated with a large effusion, less than 1 a small, and medium in between. It's important to note, however, that there can be a localized effusion that is loculated that can cause a tamponade. Not all large effusions are greater than 2 centimeters, so there's some give and take in these rules. So let's explore a few ultrasounds. Over here, there's a question being posed. What view is this, and where's the probe? The view is the parasternal long, and you can tell by the typical anatomy, left atrium going through the mitral valve, and then an easy way to remember is the parasternal long, until you get used to viewing these images, is that there's this very long view of the left ventricle and the aorta. And then anterior to all this is the right ventricle. And we know in trauma cases, the right ventricle is most anterior. That's the one that gets injured in blunt chest trauma, like a myocardial contusion in a car accident where the steering wheel hits the chest. In penetrating trauma, it's the right ventricle that gets injured with, for example, a knife. And where's the probe? The probe is to the left of the sternum, aiming at a 45-degree angle to the hip if you're performing this with the dot, which is not seen on this image, located where the arrow is. Now, over here, there's another question. What's at the arrow? So let's pause this for a second and take a look. What view do we have? Well, we have the right atrium here, the right ventricle with the tricuspid valve here. Below it, we have the septum, and then we have the left atrium and left ventricle here. Above it, if this is a subxiphoid or subcostal view, we should see the liver. And in fact, we do see the liver. Here's part of it. But there's this relatively anechoic area. This anechoic area represents fluid, just like this fluid in the heart. What this shows is that this is not just liver over here, but there's fluid in the abdomen. So this patient has ascites. So let's take a look at the liver coming and going in this picture. And we can see here the liver. Now, when viewing the heart from the subxiphoid or subcostal region, we do get the right side of the heart anteriorly, the left side of the heart with its two chambers somewhat deeper and more posteriorly. But the probe must be flat in the subxiphoid view. If not, the liver will be revealed. And by changing the probe 10 or 15 degrees, I can go from heart to liver with hepatic veins, back to heart, and changing it again, I can go back to liver again. Make sure that the probe is relatively flat. So what view is seen here, and what is being imaged? The view here is somewhat tricky if you're not used to seeing imaging. What you have here is the long view of the aorta, and the long view includes the left ventricle and the aorta. This is the parasternal long. Right ventricle is up here. Left atrium, ventricle, aorta over here. Anterior chest up here. And all of this is fluid surrounding this swinging heart. And it looks like someone's jumping up and down on a trampoline at this part of the heart, the right ventricle. So this is somebody who has pericardial tamponade with the heart swinging, electrical alternans, and right ventricular diastolic dysfunction with right ventricular diastolic collapse. Now this arrow is pointing to something, and what I'm looking for is what right in this space where the pericardium is. So let's pause it right here. If we look at the image, we see the liver up here, so we know it's a subcostal view. Therefore, this must be the right side of the heart. Deeper, the left side of the heart. And you'll see that in the space, this pericardial space right here, there is something. It's not quite clear. And there's something attached to the heart. That's pericardial fat. A normal finding. And it sticks to the heart and moves with it. So that's just a normal pericardial fat pad. So now we'll take a clinical case. And these are true clinical cases. A 46-year-old female with hypertension, metastatic breast cancer, and renal disease had a fever of 105.5 and a blood pressure that was low at 78/52. She presented to UCI Medical Center with progressive weakness and a non-productive cough. Antibiotics were started for a probable pneumonia with sepsis. She was going to have a fluid challenge, and a test was performed. Well, being that this is a lecture on ultrasonography of the heart as it relates to pericardial effusions and tamponade, it's relatively clear as to what test this might be. And what we see here is diastolic collapse of the right ventricle in what's called the trampoline effect, where it looks like someone is jumping up and down on a trampoline here on the right ventricle. What should be done next? A pericardiocentesis. The etiology of this hypotension is the tamponade, and the etiology of the tamponade could either be her metastatic breast cancer, it could be her renal disease. Another case. This is a 49-year-old female in Accra, the capital of Ghana, which is a West African nation. And this female decides to take a 15-hour bus ride to a free clinic in the rural community of Tamale, seeking medical attention to control her asthma. She has a creatinine that's 6 times normal due to her hypertension. Her blood pressure is normal, and she has a good urine output, and her heart sounds are not muffled. So asthma, renal disease, hypertension, good urine output. She's receiving absolutely superb medical care by her nephrologist at a teaching hospital in the capital. Her pulmonologist, who is also quite good, cannot control her asthma during the harmattan. The harmattan is a dry season when sands are blowing from the Sahara hundreds of miles away, and it's kind of like living in the worst pollution one can imagine. So she comes seeking attention for her asthma, and a diagnostic test is performed. Now, this clinic had an ultrasound that no one knew how to use because it was donated from Germany, and there was nobody who could use the machine. And if they wanted to learn, the instructions were in German. A little difficult. But if you look here from a subxiphoid view using a small video camera, digital camera, this is the liver here, so it's subxiphoid. And here's the heart, septum over here. And you can see some diastolic collapses. The heart is swinging back and forth inside this large effusion. So this patient's shortness of breath was more than likely not due to her asthma being kicked up by the harmattan or the sands, but it was due to her renal disease causing a very large pericardial effusion and tamponade. So there are two approaches that can be used to drain the fluid and do a pericardiocentesis. One is the traditional subxiphoid approach, and another is the parasternal approach. And here I am performing the parasternal approach on this patient. It's important to note that this is in a very rural community, and the patient has no sedation, no xylocaine because it's not available, and in fact doesn't even have local anesthesia, but she's not in any pain whatsoever. The heart is quite superficial, and you can even see the needle bobbing next to the heart because you're in the pericardium and the pressure is being transmitted. This is the ultrasound after the fluid was removed, and you can see over here that there's just a remnant of the effusion remaining, and 850 cc's were removed. The patient's symptoms immediately went away. Now, normally I would not recommend tapping this patient dry. This patient is relatively dry here. What you would really like to do ideally is drain the fluid enough to relieve the symptoms, enough to make the patient in a stable position until more definitive treatment can be given. However, it was going to be a 15-hour bus ride to get her back to Accra and then be on a waiting list to have dialysis, so it was deemed important to remove as much fluid as possible. And of course, in the US, we would be using sterile towels and ideally have this done in a cardiac cath lab. If it had to be done in the emergency room or if it had to be done in the intensive care unit, it could be performed there, and you would use as sterile technique as you possibly could. Over here, there's an arrow pointing to something going on in the liver with the question of what's this? This is the subxiphoid approach, and this is a needle entering the pericardial sac, and you'll notice there's some fluid around the liver. The liver is getting a small tear in it with some bleeding. And that in itself is not a big deal and happens quite frequently. You'll see later on there's a shadow that comes in here, and that's actually a guide wire that's coming in, and a catheter will follow. Tamponade is readily visible, and we'll explain shortly as to why there's the catheter, by the way. We'll explain now why it is not typically too crucial that the liver has a needle going through it. So just looking at the anatomy here, you can see that if you go subxiphoid at a 45-degree angle, aiming towards the shoulder, one just about has to go to the area where you're going to go through a liver. But you're using a fairly thin needle, and if you recall, a person who has a liver biopsy has a very large core of the liver removed, and there are usually no untoward side effects. The bleeding will typically stop. For me, I prefer to go parasternal in one particular circumstance, and that's where there is no backup, or perhaps another circumstance where I'm worried about bleeding. So backup is typically available in the U.S. hospitals. We're not in Tamale, Africa. But the bleeding issue is the big one in the U.S., If I had somebody in DIC, if somebody who was on Coumadin and you were afraid they bled into their heart, someone who has a bleeding diathesis, I would probably go parasternal. But the information on that, in my opinion, is purely anecdotal. I don't know of any major reports showing complications by going through the liver. So it's somewhat theoretical. In this image, the questions are, what is happening here, and how should we improve this image? Well, what's happening is we have a very large effusion between the heart and what we see here on top, the liver, so subcostal view. The heart seems to be dancing around with somebody jumping on a trampoline here. It's pericardial effusion and tamponade. But I can't see the entire heart. And take note that this is only 13 centimeters down in terms of depth. Ideally, you want to be at least 16 centimeters and frequently 19 centimeters for a subcostal view. So to improve the image, I would change the depth to see this pericardial tamponade in a better fashion. Now over here, is this fluid or is this mass, whatever, hypoechoic, hyperechoic, or isoechoic? And we typically relate that to the as a comparison to the liver. So the question was really made to bring out the answer isoechoic. If you look down over here, this part here is relatively isoechoic to the liver. This over here is somewhat hypoechoic. The important thing to realize here is not what we call it as much as what is it? This is a person who had an injury to their chest, and this is blood inside the pericardial space. Now, how do we know this isn't a fat pad? Well, number one, it's rather large for a fat pad. But number two, a fat pad is essentially glued to the heart and moves with the heart. And you'll see over here, this blood, which is partially coagulated over here, is sliding independently of the heart. So this has to be a foreign body, which is typically blood inside this pericardial space. So where's the probe over here? Subxiphoid, as we just wrote. And we can tell there's the liver. There's an effusion around over here. Some more of the effusion here. And again, right atrium, right ventricle, left atrium, left ventricle. And as a reminder, not all effusions are huge. So here's a small effusion. And this again, subcostal or subxiphoid. We see the liver on top. And an effusion is a normal finding, as long as it's small. Now the question over here is, where's the effusion? Subxiphoid view. We have the heart here, the liver here. We have the heart down here. There's a pericardial effusion over here, but there's something out to the side of the heart over here. Well, what's to the side of the heart? The lung. So this is a pleural effusion as well. So we have a pleural effusion and a pericardial effusion. This is another image with the same question. Where's the effusion? Small effusion up here. Liver, ascites, with a piece of omentum hanging down here. So two effusions, the ascites and the pericardial effusion in a subxiphoid view. This was an interesting ultrasound. This was a person who had pain, also had some shortness of breath, presumably from the right upper quadrant pain. And while the person was being scanned at their gallbladder, indicated by that arrow, there was something that was noticed in this corner over here. So we'll take a closer look at it. So what was abnormal? A very active heart, desperately trying to pump inside a very large pericardial space, a very large pericardial effusion. And again, there's no exact measurement here, but take a look at the size from here to here, and you can estimate how big this is by looking at the scale. Over here, 16 centimeters, but then here, each one is indicating 1 centimeter difference. So from here to here, looking at from here to here, is probably 3.5 centimeters. Very large effusion. So now to conclude, what to remember. First, don't drive blindfolded for effusions. Stethoscopes and physical exams are great. But remember, when it comes to effusions, when it comes to pericardial tamponade, even Beck's triad only occurs in the minority of the exam. The use of ultrasonography greatly enhances your physical exam. Next, use multiple views with sonography. We've concentrated on a few views, one of them being the subxiphoid view and one being the parasternal long. One view sometimes does not show you what you want, so as with other organs, use more than one view. Next, tamponade can be drained in a subxiphoid manner or parasternal manner. Both are relatively easy. You can use ultrasound to watch your needle go in on either one. The subxiphoid has the theoretical disadvantage if you have a bleeding diathesis and you're going through the liver. But again, it's a theoretical disadvantage. And bedside sonography is a rapid, easy way to assess for effusions. But one must be wary of other things in the pericardial space: epicardial fat pads, clots, and other effusions which we've gone over. And remember, if there's acute renal failure, certain tumors, especially lung and breast, connective tissue diseases like lupus, trauma, etc., and there's hypotension, use the ultrasound. And most importantly, don't forget to use this for relative hypotension. So if a patient comes in, for example, with a breast tumor and is 75 years old with a blood pressure of 110/70 and shortness of breath, when's the last time someone that age presented with that blood pressure? Think this may be relative hypotension and this patient's blood pressure might be higher. Do the ultrasound. And lastly, if you've probably waited too long for an ultrasound, if the x-ray looks like this. Thanks very much for your attention. I hope this was useful.